So hello everyone, on behalf of EuroELSO, it's a special pleasure to welcome you today to a very exciting topic of our webinar series. We are featuring Matthieu Schmidt from Paris, France today on the topic of prone positioning during VV ECMO. If you've been following the literature lately, there are some data coming in, not yet high quality data, but something definitely we can discuss. And Matthieu is really the expert, also running an RCT that he will maybe tell us about the backgrounds. And as I said, it's a great pleasure to have you here, Matthieu, today. And maybe some last housekeeping advices. In the panel of the GoToWebinar tool, you will be able to put in some questions. Please do so at any time during the presentation of Matthieu's. I will collect the questions and then forward them to Matthieu after the presentation, so we can have a great discussion afterwards. And now please enjoy and welcome Matthieu.
Thank you very much, Peter. Good afternoon, everyone. So my pleasure to be there with you this afternoon to talk with you about prone positioning during VV ECMO. So first of all, here are my disclosures. Some lecture fees for some company, for industrial. So what is the rationale of using prone positioning? So before talking about ECMO, we have to go back to the main paper, the main manuscript that has led, that has pushed proning as a key intervention in the management of severe ADS. So this is a ProTheva trial that probably most of you already know, with the inclusion of severe ADS defined at that time by a PF ratio lower than 150. They use a prolonged prone positioning session over 16 hours per day. And as you see on the figure, you see that the prone positioning was associated with a lower 28 and 90-day mortality. It was also associated with more ventilator-free days at day 28 and day 90, and without any difference in terms of complications. So clearly, it was a big message for the IADS community to advocate the use of prone positioning in severe ADS. But if you go back to the literature, the ProTheva trial was not the first trial on prone positioning. However, it was the first positive trial with prone positioning. And if you compare a little bit the ProTheva trial with other trials on prone positioning, and to think about why the ProTheva trial was positive, we can say, first of all, that it concerned a selected population with only severe ADS. So this is probably the first key message. They used prolonged repeated prone positioning session, so it was 16 hours, and when you compare it to the previous trial in the field, it was clearly a longer session. It was associated with protective low tidal volume ventilation, and also it was used in experienced team, which explained at the end the low rate of complication. So the question of today is it interesting? Would it be interesting? Should we expect any benefit to combine two techniques that have shown to reduce mortality for severe ADS? So if we combine prone positioning plus ECMO, do we expect some potential benefits, synergistic effects? Is it feasible, and should we be worried about some potential complication? So which effect should we expect when we prone a patient on ECMO? And then you have to go back to physiology. The effect of prone positioning has been well demonstrated. The first one is the benefit effect on gas exchanges. by a distribution of alveolar inflation and a reduction in intrapulmonary shunt. When you look at the tissue, the gas tissue ratio assessed by a CT scan, you see that when you have a normal, when you have the RDS supine, you see that you have a big difference in terms of gas tissue ratio between the ventral zone and the dorsal zone. And as soon as you prone your patient, you will homogenize this gas tissue ratio assessed by the CT scan, and it's going to be much more homogeneous between the dorsal and the ventral part. The second effect that we could expect for prone positioning is to try to enhance the effect of IPEEP. And we know that for those patients on ECMO, we frequently use a high PEEP level to try to prevent the lung derecruitment induced by the reduction of the tidal volume. And by using prone positioning in that context, we can improve the lung recruitment, and also we can enhance the effect of high PEEP by reducing the cyclic recruitment and derecruitment, which is shown in that part of the slide in the middle. And we can also avoid and to prevent the negative impact of high PEEP on tidal hyperinflation. This has been well demonstrated on the right side of the slide. The third effect that we can expect if you prone your patient on ECMO is to improve CO2 clearance, and we know that proning may improve CO2 clearance if the dorsal recruitment prevails over ventral derecruitment. And in that case, you will increase the number of open unventilated alveoli, and by this way you will reduce over-dysfunction to allow better ventilation of previously hyperinflated units. So at the end, proning will help to improve CO2 clearance, but it will also decrease regional stress and strain. Another major effect of proning, which is probably the main one, is that proning might be beneficial to prevent ventilator-induced lung injury and to enhance ventilator-induced lung injury prevention, which is a very important part of ECMO management. This is why we markedly reduce mechanical ventilation on ECMO. And based, for example, with this physiological study in animals, when they took dogs, they prone the dogs for 6 hours, and then they sacrificed the dogs, look at the lungs. And when you look at the histologic lesions, which assess the lung damage, you see that after proning, when you prone your patient, you see, especially on the dependent zone, you will see much less histological lesions of ventilator-induced lung injury. So proning will homogenize lung strain, and will decrease ventilator-induced lung injury and to try to enhance ventilator-induced lung injury prevention. And this is probably an important effect of proning, and this has been suggested in this ancillary study of the PROSEVA trial, showing that the increase in survival that was seen with prone positioning did not depend on the change in didn't depend on whether the change in position improved gas exchange at 1 hour, meaning that it's not because the patient is responder that it will benefit in terms of mortality at the end. And maybe the benefits that we have seen in the PROSEVA trial is maybe based or at least based by a little bit of the benefit might be the ability of prone positioning to reduce ventilator-induced lung injury. Lastly, we should keep in mind that prone positioning might have also a benefit effect on hemodynamics. You know that when you prone a patient, the right atrium will move ventrally, so the venous return will be aided by the gravity. And you will see also that the pulmonary vascular resistance will decrease when you prone your patient, and by this way you will have a relief. This is mainly due to the relief of hypoxic pulmonary vasoconstriction, and by this way right ventricular afterload will typically force. So at that time, when we go back a few years ago, when I did this large cohort study with more than 350 ECMO patients worldwide, recruited in large ECMO volume center, you see that proning or ECMO patient was quite rare, meaning that it was not very frequent to prone a patient on ECMO. And at that time, even if it was only a few years ago, you see that only 6% of that large cohort were prone on ECMO. And more recently, and thereafter, you have seen there are a couple of small case series showing that in a very small number of patients, proning or ECMO patient might be considered as a safe procedure, and it might be associated with a significant improvement in terms of oxygenation. And the background, the rationale of that is to say that it may facilitate the weaning of ECMO. But at that time, it was not formally demonstrated. It was just an hypothesis. And also other very small case series, again, showing that for some patients, proning your patient on ECMO could help to decrease the FiO2 on the ECMO device to improve the partial pressure oxygen. And it may also improve the respiratory mechanic by decreasing the plateau pressure and improving the static compliance. More recently, we got some larger cohort. This is a cohort, a multicentric cohort from Italy, which has demonstrated that they study only the first proning session on ECMO. They show that when they look at this large number of patients who received prone positioning on ECMO, they show that proning on ECMO could decrease the pulmonary shunt. It could increase the compliance of the respiratory systems, and this improvement of the compliance will be maintained when the patient is back on supine. And it could also improve the PF ratio, meaning that you improve the oxygenation. However, despite the very large number of patients included in this retrospective multicentric analysis, more than 100 patients prone on ECMO, you see that maybe the beneficial effect that was described in that publication was maybe partially explained by the very low rate of patients who received prone positioning before ECMO. And this is very important point when you look deeper in that study. There is only 30% of those patients who received prone positioning before ECMO, which is not in adequation with the actual recommendation and the actual practice. And it means also that this population receive ECMO quite rapidly after being intubated. And now the actual guidelines advocate to use proning before going on ECMO, and if you fail to improve the patient with prone positioning, then you start ECMO. And despite this result, they show a benefit, potential benefit in terms of mortality, with a lower mortality in the prone group, with 34% mortality in the prone group compared to 49% mortality in the control group, meaning those patients who received ECMO without prone positioning. Obviously, because you have much more patients who survived, you have a longer ECMO duration in the prone group and a longer stay in the ICU. More recently, 2 years ago, in 2019, published in Intensive Care Medicine, a large retrospective study again, which compare a group of patients who received ECMO plus prone positioning versus a group who received ECMO alone. These two groups were matched at baseline based on their baseline characteristics. And as you see, the baseline matching was pretty well done. And they compare 50 patients in each group. And they find at day 30, day 60, or day 90, you see a higher survival in the group who received proning plus ECMO, and you have a higher winning success in the group who was prone on ECMO. But again, this is a retrospective study. Even if you match perfectly both groups, you have still some bias induced by this study design. And this is just illustration. If you compare the probability of survival between those groups in red receive ECMO alone versus patients who receive proning on ECMO in blue, you see that it seems to have a strong signal in favor of proning during ECMO. More recently, we published also experience of proning in my department in La Petite-Salpêtrière in Paris, and we also match proning patients with non-proning patients on ECMO, and we find again quite the same outcome, with a much lower 90-day mortality in the group where prone compared to the non-proning ECMO patient. And we see also a higher probability of being winning off and alive at day 90. And the effect of proning on ECMO seems to be important in that study, but again, this is a retrospective study with still a major bias. One important question, considering what we are facing too with the ongoing COVID-19 pandemic, is there any benefit to use prone positioning on ECMO? This is also a very recent paper published in Critical Care Medicine. This is this paper. It's an international study which has compares the outcome of the outcome of patients who receive prone positioning on ECMO compared to those who stay on supine. And as you see, in that case, pre-ECMO prone positioning was much higher compared to the studies that I previously showed you, with 76% of these patients who received prone positioning before ECMO, so meaning that they were managed in adequation with the actual international guidelines. And when you look at the quantity, the duration of prone positioning on ECMO, it was quite important, with almost in median 6 days on proning. And when you look at the outcome, again, they found quite an interesting increase of survival from hospital in the group with prone positioning, but we can be surprised by this quite small survival in this large cohort, because as you see, only 22%, only 25% of all patients survived after receiving ECMO in that large international cohort. So quite a low, quite a high mortality, but despite this high mortality, they were able to show a good signal suggesting a potential benefit of using prone positioning on ECMO with this COVID-19 patient. Quite interesting when they did a multivariable analysis to try to see if prone positioning during ECMO was a protective factor against mortality after adjustment to some baseline characteristics. And as you see, receiving prone positioning during ECMO was a protective factor against mortality. It was also a protective factor for hospital discharge. One interesting figure of this paper is the estimate risk of death on discharge by time in prone position. And as you can see in red, there is a gradual decrease in the probability of death associated with the duration of prone position. More recently, a few weeks ago, because it was published in 2022 in Intensive Care Medicine, this is a meta-analysis with individual data of all the retrospective cohort that has been published so far. And you see that when you pull all studies published so far about prone positioning on ECMO, and when you look at the survival, you see that you have a strong signal in favor of proning on ECMO to increase the survival, the overall survival of this patient. Similarly, when you look at the hospital survival by putting all these retrospective cohort, very recent retrospective cohort, you see again a strong signal in favor of prone positioning. And when you just look at the hospital survival in the 4 study that have a matching process, meaning that both groups are almost comparable, you see that this strong signal in favor of proning is still present. So an important question in clinical practice is, for which patient should I try to prone? Which patient should I try to prone? And this is a complicated question, because it's in ECMO, on ECMO, it's quite difficult to define what is a prone positioning responder, because you can't rely on PO2, because PO2 will depend on many factors on ECMO. It will depend on the FiO2, it will depend on the ECMO flow, the FMO2, even the cardiac output, which will be modified by the prone positioning. So after brainstorming a little bit, we think that a way, maybe the most fair way to define a prone positioning responder on ECMO is probably to base or judgment on the compliance, because you can't rely on PO2, you can't rely on PCO2. So probably to define a responder, a point positioning responder based on the compliance of the respiratory system, is probably a fair way to define a point positioning responder on ECMO. And when you look at this slide, this is the use of EIT just to illustrate that for 2 patients with severe ALS, you can see dramatically a different response to point positioning. This is the first patient on the top. It's a patient which has a gain, which has a compliance gain after point positioning. When you look at with EIT, you see the distribution of the tidal volume over the 2 lengths. And as soon as a point positioning has started, you see when it's PPH 0, you see that you have a better distribution of the tidal volume in the dorsal part with more blue, and this is going to be homogenized over time until 16 hours, after 16 hours, and then back on supine, which it's called SP. You see that the blue, good distribution of the blue color, meaning that the tidal volume is much more homogeneous. And when you look at in the line, underlying line, when you look at the local compliance variation, you see more and more blue, meaning that you have increased the local compliance by putting your patient on ECMO. And this increase, in this compliance increase, is still present when the patient is back on supine. On the opposite, at the bottom of the slide, because sorry, I can't show you with arrow. So when you see at the bottom of the slide, you have an example of a patient with no compliance gain. When we prone this patient on ECMO, you see that the distribution of the tidal volume was almost similar over time over the prone positioning session. And when you look at the local compliance variation, it was almost nothing. And when the patient was back on supine, the figure was almost the same compared to before prone positioning. So clearly, we will have some patients who will have a good response on ECMO, of prone positioning on ECMO, and all the patients with no compliance gain. And with one of my PhD, we try to investigate and try to find some surrogates to see before proning if this patient will be a good responder or not. And based on EIT, you see that there is an index which is the VT dorsal and the VT global ratio. Whatever the index is not very important. This is just the expression of the percentage of the tidal volume located in the dorsal region. And when you see a patient who are called PCG+, meaning that the patient who has an increase of the compliance after the prone positioning session, you see that this ratio was very low before prone positioning session, meaning that most of the ventilation was done in the ventral zones, and not in the dorsal zones. And recently, in another paper, we also confirmed this finding with using the CT scan, and when you have a computed analysis of the CT scan before proning your ECMO patient, you see that if you just have a look at the dorsal zone, you see that most of the zones are non-aerated. And this is not different between patients who will have a compliance gain and those who will not respond to prone positioning. The main difference is mainly on the ventral zones. And you see that for those patients who was mainly non-aerated or poorly aerated zone on the ventral part, on the ventral sections of the lung, those patients will probably not respond well to prone positioning. So it might be interesting to push for prone positioning in those patients with high level of poorly or non-aerated zone on the dorsal segment, but with still hyper-aerated or normally aerated zone in the ventral segment. Another important question is when to prone, and clearly I don't have the right answer to show you. I just show you that there is in fact two opposite strategy. This is a strategy that is performed in Laurent Papazian's team in the south of France in their paper published in Intensive Care Medicine in 2019. Their criteria for prone positioning during VV ECMO was mainly when they faced to a persistent hypoxemia despite maximal ECMO blood flow at 100% FMO2 and FiO2, or when they fail to wean ECMO after at least 10 days on ECMO. So in fact, they use prone positioning mainly for patients with refractory hypoxemia on VV ECMO, or for those patients who are on ECMO for too long time. I'm not convinced that this is the right target for proning on ECMO, because if you look at the ProSEVA trial, the ProSEVA trial was positive because this intervention occurred very early in the IRDS course, and probably by analogy with that trial, and also if we believe that prone positioning, one of the main effects of prone positioning is probably to reduce ventilator-induced lung injury, or at least to enhance ventilator-induced lung injury prevention, probably using early prone positioning on ECMO might be beneficial. But in fact, I think no one has the right answer for now. Practical consideration to prone your ECMO patient: you have to keep in mind that there are some formal contraindications which are almost the same than with a non-ECMO patient. So you have absolute contraindications, which are suspected raised intracranial pressure, spinal instability. You have some high-risk related contraindication, and probably should be discussed case by case, as a recent sternotomy, severe hemodynamic instability. And you have other related contraindication, but in my experience, it's possible to prone this patient with open abdomen or pregnancy. We have prone pregnant women during the during the COVID-19 pandemic. For practical consideration, I think this is something that should be trained using, for example, simulation. We do simulation in our department, especially for the new nursing staff and new medical staff. In fact, you need to be 6. Unfortunately, I had a video, but with the internet connection, the video is too heavy for the internet connection, so I can't show you the video. But in fact, you need to be at least 6 experienced staff involved for the procedure. You will have someone at the head. Someone at the head will secure the endotracheal tube, will secure with the second hand, will secure the jugular cannula. You will have someone at the feet of the patient, and this person has a key role, because this person will drive the procedure by holding the cannula and by holding the circuit, and to maintain the circuit loose and to avoid any tension of the circuit during the procedure. And then you have 2 additional staff on each part, on each side of the bed, to do the double sheet techniques for turning. So before prawning, we always have a meticulous checking of the that all ECMO cannulas, that both ECMO cannulas are secured. We use thin hydrocolloid dressing for pressure cell prevention. Normally, we also check that the drainage cannula is almost in the right atrium to prevent, when you have abdominal pressure, you may face to a reduction of the ECMO flow by an increase of the abdominal pressure. And then we use cylinder shaped pad or dedicated helmet. This procedure is pretty well described in this paper published in Intensive and Critical Care Nursing. And this is just an example of patient that we prawn in my department. We use a dedicated helmet which secure the head of the patient, which secure as well the jugular cannula. And by this way, we do not need to move the head of the patient, and we keep both arms along the patient's body. With this mirror, you can have a look at the endotracheal tube. You can also be sure and you can check every hour that there is no compression of the eyes of the patient, and it will also avoid any plicature of the endotracheal tube. You may keep in mind that you may see some potential complications, but if you are well trained, if you have simulated this procedure with your medical and nursing staff, it's not a big deal, it's not so complicated. You may see some transient desaturation, lower ECMO flow, especially if your drainage cannula is too low. If the drainage cannula is too low in the inferior vena cava, with the pressure on the abdomen, it may decrease the ECMO flow. You may see some hemodynamic instability. Accidental extubation should be avoided, and if you really secure the procedure, you will avoid this kind of complications. Same for decannulation. In my experience, I haven't seen any decannulation for now. Other complications will occur during prawn positioning. It's mainly pressure ulcers. It's not easy to understand why some patients will have pressure ulcers after just one prawn positioning session, whereas other patients will have more than 10 prawn positioning sessions on ECMO without any pressure ulcers. And sometimes we have to increase the sedation and paralysis. In fact, potential complication of prawn positioning has been reviewed in this systematic review, and the conclusion was quite straightforward. Prawn positioning on ECMO can be performed safely when it's carried out by an experienced and skilled team. And for that, I think simulation, it's a very helpful tool to improve the procedure. So as you see, there are still many open questions about prawn positioning on ECMO. Which patient is not clear? What is the right population? What is the timing? What should be the best timing for prawning on ECMO? My personal opinion is to do it early, like many interventions in IRAS, but I can't formally demonstrate it. What should be the duration of the prawn positioning session? By analogy with the ProSeva trial, we do 16 hours, but maybe longer session could be interesting. What are the cessation criteria? And for that, you need to find the way to define what is a prawn positioning responder on ECMO. And about complication, I think we have now in the large ECMO center quite a large experience, and we have almost all the same conclusion that complication occurred very rarely if you have a skilled and trained team. So based on this editorial published in Intensive Care Medicine asking for the time for randomized trial on that topic, the answer is yes. We have performed the Prawn ECMO study, which is a multi-center randomized controlled trial. The main objective of this study was to assess the efficacy of prawn positioning on the time to successful ECMO weaning within the 60-day following randomization in patients with VV ECMO for severe ARDS refractory to conventional therapy. The primary endpoint will be the time to successful ECMO weaning within the 60-day following randomization with a competitive risk, which is the mortality. So in fact, the intervention will be to prawn or ECMO patient within 2 hours after randomization during the first 4 days. So meaning a minimum of 4 prawn positioning sessions, and it could be extended to more sessions if the physician in charge of the patient wants to do more. On the opposite group, in the supine group, prawn positioning was not allowed, and the patient was maintained on semi-recumbent position on ECMO. So this is the design of the trial. So the ECMO decision was not protocolized. It was based on the clinician discretion. As soon as ECMO has been started, the patient will be randomized. If he's randomized into in the prawn group, he will receive at least 4 prawn positioning sessions. If he is on the supine group, he will be maintained on supine for a maximum of 60 days. No crossover possible. We did a little bit few crossover were done for very profound hypoxemic status on ECMO. And we will compare the time for successful ECMO weaning with a competitive event, which is going to be a death. So this trial, the recruitment has been completed. Thanks to the COVID pandemic, we have included the maximal, the scheduled number of patients, which was 170 patients during an 8 months period. Actually, we are monitoring the data, and hopefully I could show you the results maybe in a couple of months. We expect the results in the coming months. It will be mainly COVID patients, and it's going to be quite, in my opinion, it's going to be maybe difficult to translate this result into non-COVID patient, because this study was designed before the COVID pandemic with hypothesis based on the ECMO duration for non-COVID ECMO patient, and we have seen that ECMO duration for COVID was much longer compared to non-COVID patients. So we'll see the result. I don't have the results at all for now. So as a conclusion, prawning on ECMO could be an additional cheap way to further prevent ventilator-induced injury and maybe to enhance ECMO weaning. It's a safe procedure when it's done in experienced medical and nursing team. And again, I really insist on that, but I think simulation is very important, useful, efficient to be prepared to prawn your ECMO patient. It's still underused, even if we have seen during the COVID pandemic an increase of the use of prawn positioning on ECMO. And there are still open questions about the best timing, about potential synergistic effect. And for that, maybe the prawn ECMO trial, we are waiting for the result to eventually answer to a couple of these questions. Thank you very much for your attention. Thank
you so much, Matthieu, for the great presentation. And really could show that in the last very few years, quite some substantial data on that topic came out, including the meta-analysis, and all these trials, even though not randomized, do support that what we saw from the ProSaver and other trials may translate into ECMO patients. So my conclusion, and this is what we do for many years, is that we do routine proning on ECMO already, and of course we are daily waiting for your trial, and we hope that this further supports our doing so. Now there's quite a lot of excuse me?
No, maybe I said.
Yeah. Actually, during your presentation, I was thinking, what would we do if the trial was negative? Because I still would be kind of in favor of keeping up our practice, but then we can discuss if that really happens. There's quite a lot of questions coming in, and the majority of the questions you already summed up in your slide, where you said we have quite some open questions about the timing, about the when can we do the cessation and ventilator setting. Maybe you can share a little bit with us how your practice is. For example, in terms of ventilator setting, you said that one of the benefits of proning may be estimated when we see an increase in the compliance, right? Now, when we talk about compliance, we also will have to talk about PEEP. What's your strategy on setting the PEEP when you put the patient into prone?
In fact, we use like all high ECMO volume center, we use ultra protective mechanical ventilation, meaning that we markedly decrease the tidal volume, the respiratory rate, and if you do that, you will induce lung de-recruitment, so you need to increase your PEEP. To set the best PEEP is not easy at all, because the best PEEP could change from one patient to another. It's not the same level for all patients. But we use high PEEP level. And in fact, what we have seen with the study on EIT is that frequently when you prone your patient, the best PEEP is frequently lower, because you have a higher recruitment based on the physiology of proning, and your PEEP level, your best PEEP level, optimal PEEP level, is frequently lower. So when we prone a patient, sometimes we decrease the PEEP. What you have to keep in mind is to re-increase the PEEP before putting back the patient on supine, to keep and to maintain the benefits that you get during the prone positioning session.
Right. Now, I was happy that you showed the sub-study of the ProSaver trial that looked at some markers of those who died and those who survived, and that it could be clearly shown that gas exchange variables are not associated with outcome, right? So in other terms, we cannot call a patient or we cannot say the patient profits or does not profit from proning by looking, for example, at oxygenation. And this is what I keep on telling people. If the patient doesn't improve in oxygenation, it doesn't mean that you shouldn't go on with proning, because you will only be able to see the effect after 28 or 98 days in terms of mortality, right? Unless you have some contraindication because your patient crashes in prone position. And that was one of the questions also raised here by some participants. Now, the other issue, and you already mentioned that it's unclear. What's your practice and how long do you keep on going when you're the treating physician? Which indicator will tell you that now the patient can be kept in supine position?
In fact, as you said, it's not clear how to evaluate the potential benefit because so we base it on the compliance. We routinely, I think all our ECMO patient has at least 1 or 2 prone positioning session. And if the compliance is improving with prone positioning station, we continue it. And for some patients receive 15 prone positioning sessions during ECMO, others receive only 3. But as you say, if if the rationale is to say that prone positioning might be beneficial by increasing or by enhancing ventilator-induced lung injury prevention, in fact, you should do that for all patients. And in our clinical practice, we prone all our ECMO patients. We push prone positioning when you see a compliance of the respiratory system improving after 2 or 3 sessions. But almost all our patients are at least 2 or 3 prone positioning sessions before taking a decision to continue or to stop.
Okay. Now, we've seen a proportion of patients with COVID who were almost ready to wean from ECMO and then got their second or even third hit and sometimes even had a complete whiteout of the lung. Will you in these patients again go to prone position with the same rationale?
Yeah.
Yes. Okay.
Yeah, so the connection is not good.
So I couldn't hear you, but I didn't hear you, Matthieu. You may want to try again. If this keeps up being a problem, we could also try without video, but maybe you try to give your answer again, please.
Can you hear me?
Yes, now.
What was the question? I didn't hear.
Basically, you had answered the initial question. You just had repeated something, but I think if it's lost, it's lost. That's not a problem. One of the issues, and we have discussed that in a previous webinar when you were giving a presentation on how to optimally ventilate a patient on ECMO, and I think I want to bring this up again, is neuromuscular blockage, right? Because when you say Prozeva is sort of the holy grail of some very decent trials supporting the use of prone position, I'm still surprised that some colleagues nowadays say, due to other trials, they say, yeah, they prone on the one hand, but they don't give neuromuscular blockers anymore. However, if we look closely what they did in Prozeva, you have to say Prozeva is not a trial only of proning, but it's also a trial of very strict application of neuromuscular blockers. So how is your approach with that regard?
Exactly in lines with that. We use frequently neuromuscular blockades during the procedure. And this is also why I think that prone positioning should be done early and not when the patient is refractory to everything. When the patient is with a profound hypoxemia despite ECMO with full flow and high flow, high FMO2 and so on, I think it might be too late to think about proning your patient. And for that, it means that during the first, let's say, first week, our patient is frequently deeply sedated, also because the respiratory drive is very intense during that initial period. And during that time, because the patient is going to be deeply sedated on neuromuscular blockade, then it's a good timing. It's a good time to prone that patient during that period. So we use neuromuscular blockades almost every time when we prone a ECMO patient, like they did in a Prozeva trial.
Right. Now some more questions of our participants. What is your expectation in the prone ECMO study? Do you expect that prone ECMO patients will be on ECMO for a longer period of time than non-prone ECMO patients?
It depends on the mortality. You know, if you have a lower mortality in the prone group, yes, I will expect that those patients who receive prone positioning on ECMO had a longer ECMO run, just because they will survive compared to other patients who passed away more quickly. So
Right.
that's why mortality is a competing event, because the best way to be rapidly weaned from ECMO is to die early.
Right. Okay. I'm just going through the questions, and I think we have answered many of them in a way as good as it is possible according to the data. There's a question concerning the device where you secure the head in prone position, if that's also suitable in patients after tracheotomy, and I suppose that's the case. Maybe you want to comment on that?
Yes, it is suitable. It might be suitable for patients with tracheotomy, but in fact, in practice, we don't prone much when the patient is on tracheotomy. When the patient is on tracheostomy, it means that your main objective is to awake the patient. And if your main objective, if you do a tracheostomy, is because the patient could be awake, could be participating, could have early rehabilitation, and so on. In that case, I think thinking about prone positioning is too late. So
Right.
that's why we don't prone patient with tracheostomy on ECMO.
Right. There's a question on the frequency of bleeding with prone positioning. That's something that we don't really see. Of course, if we already have an issue with the cannula, we may consider not proning, or at least trying to adjust for the place where we have the bleeding, because yes. Now you're lost
Sorry,
again.
there is a delay, there is a lag between. Maybe I turn off my
Camera? Sure.
Yeah, turn off the camera. Is it better?
Yeah, it's good.
Is it better?
Yes, it is. It is.
No, we haven't seen we haven't seen an increase of bleeding risk with prone positioning. It has not been described also in all the large cohort published so far. And I think you have to check both cannulas before the procedure to be sure that there is no additional risk. But in fact, it's not a big concern for prone positioning.
Right. So I mean that's sort of a personal view that I'm sharing here also with you, even though I'm just the moderator. I think until we have even better data, proning really is something to consider. Some questions came in on how the intensivist can start the discussion in a multidisciplinary team. I think in Paris you're beyond that point, because that's really part of your routine. You mentioned that simulation can do a really good job, and of course, if you want to introduce a system like that, you will have to educate your people that considering the data that we have at hand right now, this seems to be a very good thing to do. Any issues or any considerations on how to implement such a program?
I think first of all, you have to consider that it's just an additional procedure in intensive care environment. So it's not so complicated. You have to convince your nursing staff after discussion, but after having simulated the procedure for a couple of times, everyone will agree that it will just take 10 minutes. But you need to formally to have a formal procedure where everyone knows what is his role in terms of the procedure, with the person at the head, person at the feet, the two person on each side of the bed. And if you do that, if everyone is sticking with his role, I think it's a great team moment, and it should be simulation is very important for that, I think.
Yes, I agree with you.
I couldn't show you the video which showed the procedure because of this, but never mind.
Yeah, I agree with you on the description of the moment, because when we prone patients, not only but also do mobilization on ECMO, we call it like a family party at the patient bedside, because all of us come together. And maybe that's just a flavor from Vienna, and of course I don't have any data to back that up. We don't do complete proning, we do 135-degree, which is, in my opinion, much more easier to do with these patients. So routinely it takes three personnel to safely turn a patient. If it's a very obese patient, sometimes it's 4. And especially in these patients with that 135-degree proning, you may also correct for any cannula issues that may be more complicated when you do 180-degree. However, I will suppose that this will follow most of your center's regular routine practice. All right, Matthieu, is there anything you wanted to comment on? Because we are coming to the end of the hour, I do hope that we have answered all of your questions. Matthieu, any final comments from your side?
It was a nice session with lots of questions, so it was great.
All right. Okay, so Matthieu, I would be very glad to see you very soon, namely in London. This is going to be our annual in-person meeting, May 4 to 6, London, UK. Registrations are running, and for now we are very sure that this can really take place in person, and it would be very great to see all of you and to hear experts like you, Matthieu, on a series of other important topics. And with that, I would like to thank all of you for your participation. And Matthieu, thank you very much again for sharing your expertise with us.
Thank you very much. Invitation.
And don't forget, you're only safe if your venous line is blueberry and your arterial line is cherryberry.
Thank you very much. See you in London. Bye-bye.
Bye-bye.